Always make sure your patient undresses to expose above the elbow. Look at the hand, inspect it for swellings, abnormal colours, scars. Turn the hand over, examine the palm, look at the colour of the fingers, any swelling or abnormal areas. Look at the thenar area for the muscle bulk and once again the skin. Palpate the hand. Feel the wrist joint from radial to ulnar for any swelling or tenderness. Palpate listus tubercle and just distal to that the scapholunate ligaments. The anatomical snuff box is palpated for any tenderness of the scaphoid area. You palpate the metacarpals, starting from little metacarpal to the middle and index, and lastly the thumb metacarpal. Feel for any. Systematically palpate the rest of the hand for any. Examine the palm of the hand, palpating the finger tips, looking for a phelon or a pulp abscess. Look at the line of the flexor tendon sheaths, palpate them for any tenderness or swelling in the tract. Palpate the volar aspect of the wrist, over the carpal tunnel, the ulnar tunnel, Guyon's canal, and palpate the fingertips, looking at the capillary refill, is normally less than 2 seconds. Allen's test can be performed, and this is to evaluate the patency of the ulnar and radial arteries as well as the arterial arches. The patient is asked to make a fist to squeeze the blood out the hand. The radial and ulnar arteries are compressed simultaneously. The patient opens the hand and the hand is white. Opening one of the vessels should see a vascular blush. The base of the thumb is stabilized and the FPL is assessed. The wrist is extended and FDS is assessed. These are individual acting tendons and are assessed in turn. FDP tendons have a common muscle belly. These are assessed by stabilizing the MPJs and RPJs and assessing this tendon en masse. APL and EPB constitute the first dorsal compartment of the wrist, and their strength is assessed with the thumb extended. Patient is asked to make a fist, and this is extended and allows one to examine the insertion of ECRL and ECRB, this being the second dorsal compartment of the wrist. The patient puts the hand flat on the table and the thumb is extended. This is EPL and the strength is assessed as follows. The fourth and the fifth compartments are assessed by extending the MPJs, and the extensor tendons are evaluated, as well as EDQ being the fifth compartment. The last compartment is EDQ, assessed by ulnar dorsal deviation. On the palm, assess the thenar and hypothenar muscles. Opposition against resistance, test the strength of the thenar muscles, and abduction of little finger, test the hypothenar muscles. The lumbricals cause flexion of the MPJs, and the muscle bulk can be assessed in the first web. Sensory examination. The radial nerve supplies the first dorsal web space, and compare both sides for equality. The median nerve is assessed by feeling the pulp of the index finger, and the ulnar nerve is assessed at the tip of the little finger. Radial nerve motor function is assessed by extending the tip of the thumb, as well as by dorsiflexion at the wrist. Median nerve function is assessed by the OK sign, checking FTP as well as FPL. The intrinsic muscles are tests of ulnar nerve function. This is assessed by crossing of fingers. The power can be felt at the first dorsal interosseous muscle. The grind test assesses the basal joint of the thumb. If this is positive, this test reproduces pain. Finkelstein test for de Quervain's tenosynovitis. The thumb is held in the fist and ulnar deviated, causing pain along the tap test for carpal tunnel syndrome is positive with an irritated median nerve and causes pins and needles in the distribution. Phelan's test is hyperflexion of the wrist for 60 seconds, and if the symptoms reproduce, this is a positive test. Frohman's test for ulnar nerve function. This is a normal test. The patient has ulnar nerve presence. If the ulnar nerve is deficient, FPL is used.